Okay, good afternoon to you all. So, I'll be speaking on stabilization of the mechanically ventilated patient in the emergency department. So, the learning objectives of this session will be, how do you do stabilization of these patients in terms of airway breathing, managing a crashing ventilated patient. You know that most of the ventilated patients suddenly they become hypotensive or hypoxic. Especially using how you can use point of care ultrasound by assessing the fluid management in such patients, and how actually the third part will be that how do you do post intubation analgesia and sedation. So let us take one by one. So you see that in a patient, crashing ventilated patients, either it can be due to peri-intubation collapse, or hemodynamic and ventilation collapse, or hemodynamically stable patients with ventilator dysfunction. Three scenarios can occur. But we are going to discuss two conditions. The patient suddenly become hypotensive, what do you do? So, how do you actually predict that these patients can collapse? That is the idea of peri-intubation collapse. Prior to intubation, the preload, remember that you have to preload the patient with some crystalloids. Remember the famous mnemonic of HOP killers, that is hypotension, hypoxia and acidosis. You can say 3H as well. And how can you do really continuous hemodynamic monitoring, reduce the dose of sedative during the RSI in a hypotensive patients, to prevent that. And remember that you can do also, suppose it's hypotensive, stabilize the physiology before actually intubation. That is the meaning of that. If the patient is agitated and hypoxic, try to develop strategy of delayed sequence intubation, use of push dose pressors, if the patient is hypotensive. That will, I'm sure, most of the emergency physicians sitting here will understand what you mean by the push dose pressure. We use here is epinephrine here, or you can use phenylephrine, but in the ED, many people they use epinephrine. Or you can do emphasize lot of role. Most of the people after intubation, what should be your post sedation, post intubation package in terms of analgesia. So you remember the famous mnemonic DOPES. So that is when the patient becomes desaturating, what do? Either it can be due to displacement of the tube, or it is obstructed tube, or the patient had developed pneumothorax, or there is equipment failure, or there is stacked breaths. How do you immediately respond to such situation in the ED if the patient suddenly develops? First, you immediately disconnect the ventilator, oxygenate him with 100% with bag mask ventilation. Check the tube position. It is very important. How do you do that? We come to in the subsequent slide. Next is the trick the ventilator. That is what we have been learning since morning. Trick the ventilator, and how you can pick up sonographic evaluation of pneumothorax. So as we said, the first part is the patient goes disconnect the ventilator and oxygen with 100% oxygen with mask. How do you actually check the tube position? There are three methods. We know that there is 5-point auscultation. You can use capnography, or you can use point of care ultrasound. So it is easy now to do point of care ultrasound. You can check the lung sliding. Is it equal or unequal, or there is no lung sliding present either, or it is dislodged totally, or it is in the right main stem. You can check on the side, or immediately you can go and check on the trachea itself. Next is, this is again not that somebody else will take this. How do you tweak the ventilator, and we'll learn in the next session. But how do you pick up pneumothorax in sonographic evaluation. I am sure most of the people sitting here are very well aware of lung sonography. So please raise your hand who does regular lung sonography in their clinical practice. Just raise your hand. Yeah. So almost 60% of them. So I'll just touch upon it. May be a revision for you, or just a thing. So what you do is you do classically lung sonography. You can do by the linear probe. Remember to start with, and you see here that keep the probe longitudinally. You will find that between the two superior and inferior rib you see a white line. White line, it is moving, which is sliding. You can see that where my mouse is, it is sliding. So that means there is a, you can see the visceral and parietal probe moving with each other. So what you see actually on the B mode, when you talk about B mode, you see the classic. You can see the bat wing appearance. Okay, bat wing appearance. You can see here. This is white line is this, and this there is reverbation image of another one. This is called as the A profile. Okay, so there is A profile, and you can see it is classically called as marching of ants. And when you do a M mode, you will find what is called as the seashore sign. Okay, so this is a trivia from the normal lung, right? Bat, just look at classic bat sign, and this is the space what is called the Merlin space where you like to see the activity. This is a dry lung actually. This is what I was talking about of the marching of ants. And this is the classic, what is called as the A profile. These are nothing but the reverbation images. You can see that? This A line, equidistance from here, from the skin surface to the pleura to again A lines. So these A1 lines, there are multiple reverbation images. What you classically describe as the seashore sign, when you put a M mode, this is the C, this is skin subcutaneous tissue, this is C. And you can see the granular part of the lung, which is called as the shore. This is a classic seashore sign. That means the lung is okay. In case of pneumothorax, there will be absent lung sliding sign. There will be presence of lung point. Okay, and when you do a M mode, they call classically you will find the stratosphere sign. It is also called as the barcode sign. The most highly sensitive sign is the lung point to evaluate if there is a pneumothorax. Very important when you are looking for stabilization of the patient. In some cases, what we do is when you are doing ultrasound guided rapid sequence intubation, in the pre-oxygenation phase itself, especially in trauma patients. So to find out, you can find out either a existing pneumothorax. Okay, when you are doing, there are three phases of ultrasound guided RSI. So when you are doing actually tubing the patient, you can be well advised to find out either a sitting pneumothorax present there. It has three phases. In the pre-oxygenation phase, you can find out that. Number two, you can also find out either a impending crashing airway, either a paratracheal hematoma, either a midline vessel. Okay, when you are doing pre-oxygenation phase, you can also find out where the esophagus is, right or left. So when actually you are intubating by use of ultrasound, you can find out that within the time frame given for pre-oxygenation in rapid sequence intubation. That is 3 to 5 minutes. The study which we did, actually we finished within 1.5 minutes. You can do a quick survey. And many a times airway breathing problems comes together, especially in a trauma airway. So this is beneficial. Okay, you have tubed, then later on also it becomes easy. So this is what I was talking about. Okay, this is lung sliding. You can see on this side. and you can see a absent lung sliding sign on the other side. You see the white line is not moving. In one video the white line is moving, the other video the white line is not moving. It can also happen that if suppose there is a right mainstem bronchus intubation, or the tube had dislodged and gone to the right side. So what will happen? There will be lung sliding present on the right side, but there will be absent of lung sliding on the left side. And that is also possible when you are actually tubing the patient also, you can make out that, okay, when you do. In the dynamic RSA, if you are more keen in reading that paper, you can read the ultrasound guided RSA by our group. So this is what I am talking about. When you put an M mode, you see the classic barcode sign. The third, which I was speaking about, is the lung point. Okay, it is 100% specific for pneumothorax. It is a transition zone, where from the aerated to the non-aerated, area, the collapsed area. This is normally this is how we see. Put the probe and see the transition here. I'll show you how it comes. You can see the part of the pleura is totally the absence of lung sliding, and one part there is moving lung, moving lung. You can see the moving parietal and distal pleura here. So this point, the junction between this area from moving and non-moving is called as the lung point. It's highly specific for actually pneumothorax, because absent lung sliding sign can also be there in case of pleural fibrosis. Okay, so where there will be no lung sliding. Right mainstem bronchus intubation, absent lung sliding. Right, massive pleural effusion, totally collapsed lung. So that also causes poor lung sliding. So it is lung sliding is not the only sign. This is the most specific sign. The second part is of the learning objective is the patient is how do you affect the if the patient is hypotensive, in such patient what you do, right? And it's very common to use the fluid management status by using point of care ultrasound. A patient who has become sick, desaturating, either you have overloaded the patient in the ICU or the patient has got ARDS. It's very important to say both things can happen in the ICU, in the critically ill patients, right? So how do you assess such patients, right? So it is important for us to use a protocol what is called as FALS protocol. FALS protocol is fluid administration by lung, limited by lung sonography. Okay, fluid administration limited by lung sonography. Somebody says the fluid abuse limited by some lung sonography. Okay, so what do you do quickly? You can see whether the left ventricular squeeze or contraction is good or not. Number two, look at the existing lung. When you do a lung, is it dry or wet, right? So the third part is look at the inferior vena cava. Or you can use inferior vena cava, but in a ventilated patient it may be a different connotation. So look at whether dry or wet lung. Very important. So, and you can guide fluid therapy based on this in the critically ill patients. So it is important for us in such patients, to look at the classic wet lung, mean it is presence of this vertical white lines arising from the pleura. Okay, they are like torch, just like you are showing a torch light in a dark room, how they will appear. So it is classic. So this is called as the B lines, and if you have more than 3 in one scan window, it is called as the B profile. And you can see the whole lung field is white out. This is also called as the waterfall sign. But it has got a smooth pleural line. If it is fluid overload, it will be smooth pleural line. Okay. So what do you do if the patient in the ICU, you have appearance of B lines in the places where you should not have B lines, because that when you go to your rounds in the ICU, normally when you auscultate, you will find some crepitations on the bilateral basis because of hypostatic crepitations due to dependent portions, right. So that is normally you will find B lines there in zone 3 or the dependent portions here. But if you find B lines laterally and anteriorly, laterally then anteriorly, the most aerated part is anteriorly, that means it has become a wet lung. So you have given more fluids or you have abused with fluids. So that is the meaning of that. So I was talking about that more than 3 B lines, and the smooth pleural line is classic in pulmonary edema. Okay. So now you have to see, we'll see in the second part of the lecture how you can differentiate this from ARDS, right? Patient may be in ICU, maybe a pneumonia has got developed, has got ARDS feature, whether it is ARDS or you have given a lot of fluids, right? The third aspect of seeing in the Pulse protocol is looking at the inferior vena cava. Okay, so inferior vena cava, the size, it correlates well with the right atrial pressure in a non-intubated patients, especially. Okay, so if you see the two extreme I will talk about, if the inferior vena cava size is less than 2 centimeter and there is almost it is kissing each other, both the walls. So that means, and the hepatic veins are not there, so that means the right atrial pressure is between 0 to 5. To another extreme, where you find, if you see clearly hepatic veins, it is a fat IVC, fat means more than 2 centimeter, there is no respiratory variability. So that means, the patient is overloaded, with the right atrial pressure more than 15, right? But remember that it's a non-intubated patient. In intubated, there will be what is called, as we see here, we say collapsibility index. There we say distensibility index. That's the opposite in a ventilated patients. So nowadays we use more new parameters rather than IVC. Okay, because it has this fallacy difficult to interpret in intubated patients. So you can use more thing other like you can use it like velocity time integral. Okay, like you can use in LVOT VTI. You can use that. Okay, same. Or if you are not sure about very calculation, you can just put a probe in the heart short axis view and look at the volume status assessment on that. If the papillary muscles are kissing each other, that means severely volume depleted. Okay. Another point you can take is heart short axis view and put in cine loop in the diastole, and if the diameter here is less than 10 centimeter square in diastole in short axis view, it suggests the patient is severely volume depleted. So why you want to club this? Because we want to see giving the adequate, in an adequate of fluid, you are fearful whether I am overloading the patient in the critical care setting or even in the ED setting. So, or in a non-intubated, you can see the classic kissing sign, you can see volume depleted to a fat IVC like this, where the RA pressure is more than 15. You can see a part of the hepatic vein, you can see here. Sorry, the mouse is not working there. Yeah. So how do you differentiate between a cardiogenic pulmonary edema from a non-cardiogenic pulmonary edema? Okay, so let's see one. So this is how you see. It's easy to understand that. We'll see some of the slides there in subsequent slides. So in ARDS, actually what happens is you will find B profile bilateral, but there will be sparing of lung, in between, sparing of lung in between. Plus you will find some, features of subpleural consolidation. Okay, you can find in ARDS. The movement of lung sliding becoming, slower because of the baby lung concept, because of the collapsed, lung. And that is how you actually differentiate between a cardiogenic pulmonary edema from a non-cardiogenic pulmonary edema It is well, it is well established by literature. And you can see, you can use it for daily monitoring purpose as well in the ICU setting. Like we are talking about, definitely a CT scan is better, for objectively assessing that. But again, you can use point of care ultrasound in your daily clinical practice, to see, actually monitor the lung issues in the ICU setting. Because there are a lot of issues in the ICU, ARDS, effusions, fluid overload, pneumonias, this can all have a great, it has got a good diagnostic accuracy in identifying whether it is air, whether it is fluid, whether it is consolidation, whether it is alveolar interstitial syndrome like ARDS, as per the paper by Daniel Lichtenstein in Chest. So the last part is actually what we do is analgesia and sedation, especially in an intubated patient. We actually use Richmond agitation sedation scale, like to keep it -2, like sedation, in such patients. So remember that this is how we actually use point of care ultrasound and to its good effect, right from when you are doing intubation to ultrasound guided RSI, to anticipate, or to manage, or as an adjunct to peri-intubation crashes, whether it is hypotension, hypoxia, in identifying that. Third is how do you differentiate between a cardiogenic pulmonary edema from non-cardiogenic pulmonary edema. Thank you. Dr. Deepak. Any questions you have, we'll take. Any questions you have, we will take.
Sanjeev, do you have a protocol of every patient that is transported to the ICU?
Yes, sir. We have a written protocol.
So
we have a checklist, transfer checklist,
Perfect.
from the ED to ICU.
I think that's incredibly important that you follow the same protocol. If you don't like the protocol, you rewrite the protocol.
Yes.
So, and anything else you can tell us regarding when you are performing a checklist? Do you have the ICU person there?
For transfer protocol?
Ah,
No. Our residents only go and drop them to the ICU. Our resident and one nursing officer, trained nursing officer, mainly the trained nursing officer, and a resident, and this thing, OTA, they go and drop the patient, hand over the patient to the ICU and come.
And if I may add on this, there is a nursing note which is written by the nurse who transfers. So there's a full note which is entered on the computerized system, and when the patient reaches there in the ICU, the nurse from there takes over. So there's a takeover note which is there.
Both
so
are
those
there.
two notes are there on the nursing side.
so we have a whole checklist similar to your operation room checklist. So if you guys are following that in the operating room, operation checklist. Is airway secure? I'm operating on the abdomen. Do you have all the images? As antibiotics?
We have the standard WHO checklist.
Yeah,
That
we have
WHO checklist is followed.
And you follow.
Yes.
Yeah, WHO checklist is followed in OT.
So that's the idea, right? You want to keep it so simple
Yeah.
and so methodic. Any other advice, Sanjeev, you have for people who are just starting out in emergency room? What other advice? You've been doing this for a long time, so give us your words of wisdom in terms of what else can be done to, you've done so many things in ultrasound. So give us your thoughts.
I feel that most of the students whom I taught are sitting in this room. So in fact, you can ask them what is their vision. My vision is that next step. We have already in last 15 years, you can see most of the people who have graduated now have faculty in different aims, and they are taking it ahead. I strongly feel is they should take the learnings which you had and spread point of care ultrasound wherever you are. You are all in top institutions. So like we did it here, spread it across the country in all clinical disciplines, and it is also now in NMC that most of the clinical disciplines should have point of care ultrasound, where it is less practiced in trauma surgery. Surgeons are less; they are practicing virtually nil, and pediatrics they have started off very recently. Critical care, it is already there in their curriculum. So most of the clinical disciplines they will have. That is one. One more vision I strongly have. I have a vision is I have trained my nurses in point of care ultrasound, where they do during mass casualty, and also when Dr. Deepak was having his neuro ICU nurses, they were practicing optic nerve sheath diameter. I think they did some work with you in with them. So that is another thing which I feel that now in India we have nurse practitioner in emergency and trauma care. There is a nurse practitioner in critical care. Nurse practitioner in emergency and critical care, trauma care was written by me, curriculum. So I have put in the curriculum itself one point of care ultrasound. The third aspect which I feel is, this is for all our students who are sitting here also, the vision is, then next step we are going to do it from 2026 onwards, is bring it to the undergraduate medical education. So I have done some work in AIIMS Delhi, 2011. So because we were really busy in other works which we are doing, bringing emergency medicine in this country. So a lot of effort has gone. So this was, off the radar of mine. So this we are going to, because already we have integrated in anatomy, sonoanatomy, sonophysiology, sonopathology. And then when they go to clinics, basics of ultrasonography, clinical ultrasound. So by the time they graduate, they will have some, this confidence that they can handle the probe, because it is the new visual stethoscope. So that is what we learned in our MBBS days, the chest X-ray. Anybody, fourth semester that we are introduced. Any physician can read a chest X-ray irrespective of specialty, because of that initiative we had early when catch them young. So it is already there, and this is what we are working on, sir, and that is what we are going to do it from next year itself across the country. So that is the vision, sir.
See, Raghu, I think what Dr. Boi has started is very, very nice. The only flea in the ointment here is that it is dependent upon him. As of today, like in the ATLS, there's a protocol that at this point we are supposed to do this. We're supposed to do a fast or a pericentosis or whatever you want to call it. It is here currently in most places it depends on the passion of the person involved. It is not as a protocolized thing that you have to do ultrasound from head to toe on every person. So when we had in the neuro ICU, we had a team at that time when Professor Mishra was there, we had a dedicated team of nurses who used to walk with me on the round and used to do a head to toe ultrasound of the patient while I am taking the round on that patient. So the lung, the abdomen, deep vein thrombosis, right from, and the obviously optic niche. So everything was done. So on the spot diagnosis we were doing for all the 20 patients. So this was protocolized, but over time it again it stopped. So unless you have a protocolized system, these things will only go up to a certain point. It cannot become a standard of care.
I think it's in the critical care world, we have Ross can tell you more. It's a whole lot of curriculum that has been added. So the fellows have to be trained, right?
Yeah.
Yes. In terms of ultrasound, they have 6 or 7 sessions. Krishna runs it, Deepak, for the whole critical care.
Now if you see, like Dr. Deepak's point, I am taking it at protocolized. Most of the people who are sitting in emergency medicine, they are trained for 3 years in point of care ultrasound. Now if you see our regulatory body guidelines, we have come out with a curriculum. In that curriculum, ultrasound is a ingrained part. So that is one. Critical care, he will definitely say.
Yeah, means in critical care now it's an indispensable part of our examination. Means we have just forgotten using stethoscopes. We rely heavily on ultrasound. One thing which I just in the context of this workshop, I use a lot of ultrasound in ARDS specifically for PEEP setting. where I can actually see the segments which is opening and the deaeration and the aeration with the help of ultrasound. So if you are performing a recruitment maneuver, the ultrasound is a good tool to actually observe the effect of your PEEP setting. Whether the lung is opening up or closing up, that you can see the appearance and disappearance of B lines which can be seen, specifically the dorsal segment. If the patient is in prone, you can actually monitor with day-to-day progress how much lung is getting recruited. So ultrasound has been now one of the essential tool even for management of ARDS. A false protocol which Dr. Bhoye has already spoken about, shock, these are a lot of interrelated phenomena which are occurring where you want to give fluid, where you don't want to give fluid. In the lung you want to keep it dry as much as possible, but on the other hand you don't want kidneys to suffer. So it's a very fine line, but ultrasound helps you in attaining that balance. Should I give fluid, should I not give fluids? In an ARDS patient it's an important decision, because you know if you give fluids it's going to leak into the alveoli, right. So ARDS specifically, the ultrasound is a very good tool in setting, looking at the diaphragm as well, how weak is the diaphragm during the weaning as well. So these are the whole new applications which has come into the ventilatory part of ultrasound.